So today we're going to just kind of go over, I've created like a tip sheet for you all to use as a resource, kind of as like the patients come in, to use as patients come in and you're admitting them and you kind of find these things on them, you know, different wounds on them, kind of like what you could do, and then when you should consult the wound care nurse for further evaluation. So we'll just go through a PowerPoint this morning and then we'll play a little game as well. Okay.
Can you ask them if they
Can you hear okay?
Yeah.
Okay. If you can't hear, just let me know.
I hope they can.
Can you guys see the PowerPoint too? Okay. All right, so for patients that are incontinent, have like dermatitis on their skin and their skin folds, and then stage 1 pressure injuries. For moisture-associated skin damage, you can place calmoseptine. So you really want to make sure that they're clean, allow them to dry, and then place the calmoseptine, like a thin layer of the calmoseptine. You can apply to the affected areas twice a day and as needed. Even if there's open areas on the buttocks and they're having frequent stools, then you can still place the calmoseptine over the open areas as well. When you're removing the calmoseptine, if they're soiled or something like that, you don't want to scrub it completely off every time. Just remove the soiled layer and then reapply another light layer on top of that, just to kind of keep everything protected. If they have a red rash, you know, moisture with like a fungal infection, you can use the anti-fungal, the miconazole cream, apply it twice a day and as needed. You can, for patients that have this, you can always call me and I can order it for you, or you can ask the physician to order it if you'd like. Fungal rash in the skin folds. So you want to take the bath wipes and cleanse the folds really well. So like the abdominal folds, the groin or under the breast, things like that. Clean them really well, allow it to completely dry, and then you can either use nystatin powder, is what I prefer. Sometimes the cream in the folds gets really, really moist, especially if they already have some moisture in there. It just kind of makes it even worse. So the powder just kind of helps absorb that and keep them dry. Or what I really prefer is to use what we call inner dry. Are you guys familiar with inner dry from the units? Okay, so I usually just take that, clean the patient's fold, and then just lay it out as like a 1 sheet layer within the fold. And that is infused with silver, so it will help remove the fungus, and then it is absorptive as well. So if they're weeping some or they have a lot of moisture there, then it will kind of wick away that moisture to keep them dry. For any patients that have moisture-associated skin damage or having frequent stools that are at risk, you can put a waffle mattress underneath them because they are at higher risk for pressure injuries if they have moisture-associated skin damage. Or we can place them on a low air loss bed. Usually if they have open wounds on their bottom, like denudement from moisture, then I usually get them a low air loss. That kind of helps a little bit more. If there's non-blanching purple or red areas on a pressure point, you want to get an order from the physician for what we call Menolex, which is an ointment that just kind of helps increase circulation to that area. It is bacteriostatic, so it'll kind of help keep the bacteria out and provide it with some protection. You can place it twice a day. Some places you can cover with an Alevin, just because it can turn the sheets in the patient's clothing black if it comes in contact with different fabrics. And then you can always place a wound care consult for me to come in and kind of take a look at what we can do moving forward. If the heels are red, purple, or open, you definitely want to get your EHOB boots or the space boots to offload their heels. And then if they're up in the chair, make sure you have a waffle cushion on their chair, and then just turn them every 2 hours if they're in the bed. And you'll get the low air loss or the waffle for the bed. If it's pressure related, you want to place a consult for me, or there's my work cell phone number that you guys can always text or call anytime that I'm here. I'm usually here Monday, Tuesday, Wednesday, Friday from 7 to 4:30. If my phone is off, I'm usually not here, but I will get back to you as soon as I'm back in the office or back in the building. So this is a little slide about the Menolex. So it's a capillary bed stimulant used to increase circulation in the wound site area. It's a mild bactericidal, improves epithelialization, so helps healing, and then protective covering, and then it helps with pain reduction as well. I don't recommend using on the face. I've had a few patients here recently that I've used it on like the chin and the nose in the ICU, but only because the patient is sedated. So they're not moving. You just want to make sure that they're not rubbing it into their eyes or, really diaphoretic. So I try to avoid use on the face if they're, awake and moving and things like that. Does require secondary dressing, but this is really good for stage 2 pressure injuries on the sacrum. It's really good for deep tissue injuries and for toes as well. If patients have issues from using vasopressors, we put this on the toes too, just to kind of help increase that circulation back to those areas so that way they don't get necrotic toes or fingers. All right, skin tears. Skin tears are, if it's a small skin tear, you just want to reapproximate as soon as possible. So usually what I'll do is just kind of take some saline, put it on the wound bed, and then take like the large Q-tips, I call them CTAs, and kind of roll that skin back over top of the wound bed. Just kind of helps like protect it and give it kind of like a shield. If it's a small skin tear, I'll usually dress it with an oil emulsion gauze, which is kind of like an adaptic, and then cover with an Alevin. Change it every other day and as needed, but you can lift the Alevin to check it daily. For large skin tears, you can consult me. Usually, if it's pretty large, it comes through the ED. If it happens in the hospital, then definitely give me a call and I'll come as soon as I'm available to help you guys. But you can kind of reapproximate best you can. And then sometimes I'll use steri strips just to kind of hold in place, especially if it's really large. We had a patient that it was like her whole entire forearm come through the ED one time, and so we used steri strips just to hold it in place for her. The Curity oil emulsion gauze just helps keep a moist wound environment, so that way it'll kind of encourage healing. If it's a pretty large one, like if it's their entire arm or a larger area, I'll wrap with Curlex. You can put the oil emulsion gauze. You can place a telfa if you want, just to kind of give a little extra support and coverage, and then wrap with Curlex. Sometimes you'll see that if they have like a skin tear here, I'll kind of wrap the hand and then to the elbow, just to kind of help encourage any edema out of the arm, so it'll kind of help with healing as well. So it might look a little extensive, but just kind of more for swelling. You can, if you use an Alevin, I recommend placing an arrow on the Alevin of which way you want the nurse to remove it, so you can reduce risk of like re-injury. So if the skin flap is coming down this way, you want to pull this way so you don't lift the flap up over and over and over again. And that will kind of help give, I kind of do that just to kind of give you guys more comfort too, because some people are afraid to re-injure. So that just kind of helps, like, oh, if I pull it this way, it's less, or, less risk of re-injury. So I can look at it every day and assess it. If they're having a lot of drainage, you can do the adaptic with the telfa, and the telfa will kind of help absorb as well any drainage, and then wrap with the Curlex and change it daily versus every other day. All right, any questions so far?
No.
Okay. All right, for superficial or partial thickness wounds and then stage 2 pressure injuries with a clean wound bed, if the patient has multiple stage 2 pressure injuries, you want to initiate a low air loss bed or the waffle mattress, and then consult me. In Epic, if it's just you haven't spoke with the physician yet, but you want me to come in, you can place a wound care notification, and that can be nurse initiated. If you want the consult, just talk with the physician and they can place the consult. And then we can kind of go from there. If the injury has minimal drainage, you can place what we call solo-site wound gel, which is in the plain utility closet. Usually it's in that bin that has like the steri strips and the wound spray. The skin prep is usually in there. The solo-site's usually in those bins. Place a little dab on the clean wound bed and then cover with an Aleve. So that will just kind of provide a more moist wound environment for the wound, encourage healing. You can change it every other day and as needed, but again, you can always lift every day to assess. If there's moderate to heavy drainage with the wound bed, you want to clean it with saline and gauze and then place Alginate M, which is an absorptive dressing over the wound bed, and then cover with an Aleve. And you can change that daily and as needed if there's soil. I have a little slide that will kind of go over the Alginate M in just a second. If the patient is experiencing frequent incontinent stools, place calmoseptine on the buttocks to protect it and consult me. Most times, if they're having a lot of stooling, you can't really put an Aleve, and sometimes if they have open wounds and you're putting an Aleve and they're stooling frequently, it just sits in the Aleve, so it kind of makes it higher risk for further injury. So I usually just recommend cleaning them up really well, allowing them to dry, place the calmoseptine, and get a low air loss bed for them, and really focus on repositioning, pressure relief, things like that. Sorry, I'm going to try to maneuver this myself here. Okay, it's okay, I got it. The Alginate M is a calcium alginate dressing, and it's highly absorptive. So it forms a soft gel that absorbs when it comes into contact with wound exudate. It's easy to remove because it turns into a gel once it comes in contact with that drainage, and provides a moist wound environment by making that gel. It does require a secondary dressing to cover, so sometimes I'll put like a non-adherent Aleve if it's on the legs, and then wrap with Menolex, or if it's on the arm or something like that, then you can place an Aleve, or on the back you can put an Aleve over top of it. Just kind of cut it to fit the wound, and then cover with an Aleve. If it's on the legs, most times, like if it's for like venous ulcers or something like that, I'll go ahead and wrap the leg from toes to knee with the Menolex, again, to just kind of help initiate compression for the patient to get that edema out of their leg. Most venous ulcers are pretty painful, so they can't tolerate like an ACE wrap or anything like that, or compression dressing. So I just kind of start the process with that and then elevate their legs. All right, for full thickness or pressure related stage 3 and 4 venous ulcers and sloughing tissue, place a consult for me or call my cell phone. You can text me as well. And then if there's minimal drainage, you want to place Solosite gel, which is going to provide a moist wound environment, and then put an Aleve on top and change daily. If there's moderate to heavy drainage or tunneling, you can pack the wound with the Alginate M, or place the Alginate M on top and then cover with gauze or Aleve and change daily. If you have to pack, some units do have the Alginate M in a rope. I've only seen it, I think maybe on Cornell 1, but most of them come in a sheet that's like a pretty big sheet. You can cut it so that we can kind of spiral it, and that way it's easier to pack the wounds if you need to. All right, if the wounds are necrotic or black, place a consult for me, of course, or give me a call or text. You want to cover with a dry dressing and change daily if it's not draining, or if it is draining, excuse me. If it's black, dry, and stable on the heel, like no drainage, no redness, and it's not coming off, no like open areas, then you want to paint it with betadine daily and don't place an Aleve. So if it's dry and stable, it's not boggy, there's no like, infected wound underneath, that kind of just protects that wound bed, and eventually the body will push that hard eschar off, but it's pretty much a hard protective layer for that wound. So you just kind of want to let it be and let the body kind of do the rest underneath. But of course, have me come in and I'll take a look at what we can kind of do further, but just don't place an Aleve on it, because that causes your body to start performing what we call an autolytic debridement, where your white blood cells and everything will kind of start coming in to clean that necrotic tissue and push off that shield sooner than what we want. And then they have an open wound. For heel wounds, make sure you apply the boots on the patient. If they're up and walking, which I'm assuming most people that have these wounds are not very active, But if they are, you can just put a pillow under the leg to elevate or offload the heels as well if they don't like the boots. I prefer the boots though. For suspected deep tissue injury or non-blanching purple-red areas or boggy tissue on a pressure point, place a wound care consult or notification and then call me or call me or text me. Contact the physician for an order for Menolex twice a day and cover with an Alevin. And then provide pressure relief. So get an air bed. If they have more than one pressure injury or more than one wound, on the torso area, you can always get them a sand bed as well, and that will just really, it's like sleeping on a cloud pretty much. So that will really help with pressure relief. And then make sure you're repositioning them frequently. If it's a heel wound, again, apply the boots. Some people don't like how warm the boots are. So I always tell them, you don't have to always have them completely closed up. You can take the Velcro tops off and even open the bottom up so it's totally flat and their heel is still offloaded. And that just kind of helps with people who are a little more claustrophobic or get really hot and just can't tolerate them. All right, and then of course, if there's any infection or signs and symptoms of infection, a severe redness, purulent drainage, things like that around the wound, then you want to notify the physician, and then they can place a wound consult or give you, kind of take a look as well. And then make sure if your patients, which most of them will have a Braden of 18 or lower, you want to make sure you put in your pressure injury prevention order set and then get your pressure injury prevention for the patient.